Well, thank you everybody for showing up. I apologize if we had some um, issues with links and such. If you know of people still trying to join, please let them know. They should go to the UWM Math Department website. They can just Google search UWM Math Marden, and they can probably find the correct link. Apparently, for members of the general public, that link works better than what was sent by email. I'm going to give some more detailed introduction and some more detailed instructions for how to participate. But first, I'm going to introduce our dean for some welcome remarks, Scott Gronert, who's the dean of our College of Letters and Sciences.
Thanks, Suzanne, and thanks so much for inviting me to be part of this. And thanks everyone who's attending. I see you're over 100 at this point, which is terrific. This is not the way we like to do seminars and such. It'd be fun to have a reception. It'd be great to be able to chat and catch up with some old friends. But I really applaud the department for going ahead, because in this medium, in fact, one thing it does do is it makes things a little bit more accessible. And so there are probably people here who couldn't be here if they had to be on the campus. I just want to say a couple things about UWM and the department. UWM is a really special place because our mission is to bring in students from all kinds of backgrounds, all kinds of preparation, and provide them with a really high quality education. At the same time, we're dedicated to research, and our faculty is full of top-notch scholars. And so what our experiment here is, let's bring those two groups together and create some really unique educational experiences. And from my time being here, I can tell you that students and faculty both find that a very satisfying mix that we're trying to do here. When we look at my college, Letters and Science, we're at the center of all that. We do all the foundational courses for the university. Along with that, though, we lead on the research mission. We have, again, top-notch scholars across all of our departments. 60% of the research funding at the university is in the College of Letters and Science. And now drilling down a little farther, mathematical sciences really epitomizes the mission. We all know every student goes through a math department, and mathematical sciences has had terrific success, been very innovative in recent years, and helping our students succeed and get to degrees. And I'm very proud of them for what they've been doing on that side of the house. On the other side of the house, faculty is full of really outstanding scholars, and particularly across a broad set of disciplines within math. And so math is a very critical piece for UWM. We're really proud of the math department in Letters and Science. And finally, I just want to congratulate the organizing group, because not only did they find an outstanding speaker, but one who has a connection with UWM and who chose a terrific topic to share with this broad audience. And so I'm going to stop so you can go to the fun part of this, and I'm going to get off the screen and enjoy the seminar. So again, thanks for letting me join you today.
Thanks, Scott. Before the main course, actually a technical note. You may have noticed, if you're an audience member, that your mics and video cannot be turned on. So if you have burning questions during the talk, or more likely, at the end of the talk, we're going to have a Q&A time at the end. In fact, there's a window. The chat is actually also turned off. But if you move your mouse around and you can find the Zoom controls, there's something that says Q&A. If you click on the Q&A, a window pops up, and that's where you can type questions. You can type it the whole time during the talk, but we may not look at them until the end. So I would suggest you put in context. You can't put, wait, explain that some more. We won't be looking at it at the moment. So so put in some context. Can you please go into more detail about blah, blah, blah. Okay. At the end of the lecture, our colloquium chair, Peter Hennom, will moderate this question and answer session. So you can enter questions during the talk in the Q&A. We will address them at the end or at the end of the talk. Okay. So first, I'd like to tell you a little bit about the Marden Lecture. Every year, we invite a distinguished mathematician to lecture to a general audience. The Marden Lecture honors Morris Marden, who, in fact, as a professor in our department, founded our graduate program in the 1960s. In fact, the very first department at UWM to award a PhD. This really helped contribute to solidifying the research mission of our department and the university. The Marden Lecture is funded through the Miriam Morris Marden Fund. There's more information on our website, including a really interesting biography of Morris Marden. I was trying to look for highlights to share with you, but there's just too much. He was actually born in 1905, and if you think about US history, he lived during a really interesting time period. I encourage you to go to our, again, UWM Math website. Just Google search UWM Math Marden and you'll find it. And you can read this bio, which is a walk through US history peppered with names of famous mathematicians. In fact, speaking of people related to Professor Marden's biography, Professor Marden had two sons, and actually Albert became a mathematician. He directed the Geometry Center in Minnesota for a while, and Phil lives locally and became a pediatrician. I remember Philip attended the lecture last year. If either one of you is in the audience and you'd like to say hello or be introduced, if you would put your name in the Q&A, the name that you logged in with, so that I could find you, I could actually make you a panelist and you could turn your video on and say hello if you'd like. While you're doing that, I'll find something else to talk about, but are Philip or Albert here? I wonder if they were able to use the link. Maybe if they're having trouble joining, and if they join late, maybe we'll ask again after the talk during the Q&A session if either of them wants to say hello. All right. Okay, now I'm going to say a couple of words about another esteemed mathematician. That's our speaker today. Professor Lauren Ancel Meyers is an eminent biostatistician and data scientist from the University of Texas at Austin. She will talk about her work on modeling the mitigation of the COVID-19 pandemic. Yes, a timely topic. In particular, she will discuss how data, mathematics, and computing are used to measure the speed and severity of the COVID-19 pandemic, how to forecast COVID-19 deaths across the US, and how to provide guidance to various constituencies involved in making public health policy. And she graduated from Nicolet High School, just up the road, and earned a bachelor's degree from Harvard University, double majoring in math and philosophy, and then a PhD in biology from Stanford University. She is currently a professor at UT Austin in two departments, the Integrative Biology and Statistics Department, as well as the Data Science Department, the latter of which she founded. She's also the director of the COVID-19 Modeling Consortium at the university, a unit that brings together scientists, social scientists, and engineers to develop innovative models for surveilling, forecasting, and mitigating COVID-19. Dr. Meyers is a renowned pioneer in network epidemiology and the use of machine learning in epidemic and pandemic detection, forecasting, and control. Her team has built tools for the CDC and other health agencies to fight influenza, Ebola, HIV, the Zika virus, and now COVID-19. She has published more than 100 peer-reviewed research articles and has appeared in the Wall Street Journal, New York Times, Washington Post, and on NPR, CNN, and the BBC, to name a few. Named one of the top 100 global innovators under age 35 by the MIT Technology Review in 2004, she also received the Joseph Lieberman Award for significant contributions to science in 2017, given by the Center for Excellence in Education. And on a more personal note, we're very happy Lauren accepted our invitation and very proud of her achievements and her willingness to talk with us, in part because her father, Rick Ancel, was a professor in our department for many years. He just recently retired, but he still attends seminars, so we get to see him. Okay, without further ado, Dr. Lauren Ancel Meyers.
Thank you so much for that really generous introduction, and especially for the invitation. This is one of the few talks this year where I wish I could have come in person and seen all of you. I know I have friends and family in the audience, so thank you for being here. Let me share my screen and then I'll get started here. Okay, so today I introduced myself as a pandemic modeler, and if I had introduced myself to you about a year ago as a pandemic modeler, how many of you would have actually known what the heck I was talking about besides my parents? You know, probably not many of you, but now researchers like me are highly visible. We're out there using math and statistics, computing, engineering to try to build time-sensitive forecasts to inform the public and to inform policymakers. So how did I end up becoming a pandemic modeler? Well, for my friends and family in the audience who remember me as a large banged 1980s high schooler at Nicolet High School, you will know that I have always loved math. It's always been a passion. But what you might not know is that I've also always been equally fascinated by deadly plagues, deadly diseases, and the specter of the big one that could wipe out life on Earth as we know it. Long story short, by the time I got to the University of Texas as a new professor in 2003, I had kind of an unusual course of training that led me to that point. As Suzanne mentioned, I did my undergraduate degree in math and philosophy. I'd gotten a graduate degree in biology where I learned how to build models. I also worked for a little while at the National Security Agency, breaking codes. And right before I got to UT, I did a postdoc where I got to work with the CDC, build some pretty cool mathematical tools for figuring out how to stop outbreaks. When I got to UT in 2003, shortly after, the phone on my desk rang, and this was back in the days where we had phones that we just picked up, and I picked it up. It was a cold call, and the man on the other end of the line said, "I'm calling from the British Columbia Centers for Disease Control. This new deadly virus, SARS, has just arrived in Vancouver. We saw the work that you did a year ago with the CDC, and we're wondering if you could help us figure out how to navigate this new threat." And of course, I said, yes, I'd be happy to help. And that led to a lot of very interesting science, interesting modeling, and insight into how viruses like SARS spread. Fast forward 6 years, April 2009, we all just got word from CNN or whatever that there was a deadly new strain of influenza spreading in Mexico City, large numbers of deaths. This time the call came in on my brand new iPhone. It was my NIH program officer asking me if we would build a model to help the CDC figure out how to deploy our strategic national stockpile of 80 million courses of Tamiflu and Relenza, these are the antiviral drugs, to slow the spread of this new pandemic influenza virus. So SARS and influenza were serious threats, and they killed a lot of people, but fortunately, neither panned out to be that deadly plague of my childhood nightmares. But COVID is different. COVID is different not just because the information and the requests for analysis are coming in on new technology, but it's different in many other ways. So where are we today? Well, this chart is showing global deaths due to these three viruses. SARS killed around 800 people total around the globe in isolated outbreaks. It never expanded into a global pandemic. 2009 H1N1 did spread pandemically around the globe. And by the end of that pandemic, killed around 300,000 people. And COVID-19, sadly, has a body count of over 1.3 million, and it's still climbing. So why has COVID played out in such a more devastating way on the global stage than these other threats? It's kind of complicated, and it sort of comes down to two things. The first is about the deadliness of these three viruses. So this graph is showing the case fatality rate. So what fraction of people who are infected actually died from the virus. And SARS is by far the deadliest of these three viruses. About 15% of people who were infected with SARS ended up dying from their infection. In contrast, 2009 H1N1 was the mildest of the three. A small fraction of a percent of people died when they become infected. And then COVID-19 is, while it's much less fatal than SARS, it is actually somewhere between 10 and 100 times more deadly than the 2009 H1N1 influenza virus. So difference in deadliness. Now let's look at their speed or their pace of transmission. And what I'm showing you on this y-axis is something called the serial interval. So what's the serial interval? Well, imagine that I get infected and then I infect you. The serial interval is the number of days between when I first feel symptoms and when you first feel symptoms. So a short serial interval means that this virus is spreading quickly, and a long serial interval means that it's spreading more slowly. So SARS turns out to be the slowest spreader of the three. Its serial interval is 8 days. And in addition, people weren't actually contagious couldn't actually spread to others until they had symptoms. So if somebody became infected, we had a good 8 days to try to track down anyone they could have come in contact with before they started spreading the virus to others. In contrast, the 2009 H1N1 virus and the COVID-19 virus spread about twice as quickly, compounded by the fact that both of these viruses can actually spread before a person even knows they're sick, before they even have symptoms. So COVID turns out to be the perfect storm. It is just as stealthy, just as quick as the 2009 H1N1 virus, but it's far more deadly. And so that is why we are where we are today. Between the 2009 pandemic and the COVID threat, the COVID pandemic, my lab has been hard at work collaborating with public health agencies like the CDC and the state of Texas to model past epidemics so we can understand how they spread, but also to plan for future pandemics. What you see on your screen now on the left is a video of a tool, an app that we built for the state of Texas that allows them to simulate different pandemic scenarios. And this is circa 2013, so this is already outdated technology, but it allows the user to simulate all different kinds of scenarios, different levels of transmission, different levels of fatality. They can implement different kinds of vaccines and antivirals. And what's interesting about this tool is they can actually watch a pandemic play out through the lens of a crappy surveillance system. When you really can't see the data you want to see, what does that pandemic look like? And so we sort of anticipated, others in my field anticipated exactly the kind of challenges we would face today. And what you see on the right is another version of that exact same tool, but playing out in something called the visualization lab at UT. It's a room with a wall of monitors. And we developed this tool so we could actually bring in groups of public health officials and run preparedness exercises so they could go through sort of the decision process that they might face in a real pandemic. Based on the work that we did with the state of Texas following the 2009 pandemic, we, in fall of 2019, we started a very similar project for the CDC. And we were in the middle of building a national scale version of this pandemic preparedness tool when COVID-19 started spreading. And because we had this model almost completed, we immediately got requests from the CDC, from White House Coronavirus Task Force, from other policymakers to rapidly adjust the model as we learn more about COVID and make projections for how the virus might spread and what we might be able to do to control it. Well, pretty soon we were inundated by these requests. And at the time, it was my relatively small lab at UT that was trying to do analyses night and day. There were about 6 or 7 of us, some postdoc, some graduate students and a postdoc myself. And so in early March, we basically overnight stood up something that is now known as the UT COVID-19 Modeling Consortium. I reached out to my colleagues across UT, including at our medical school. I reached out to the dozens of collaborators I have all around the world that I've been working with since early 2000s, and asked whether they wanted to kind of join forces and collectively respond to all these requests, build models that help us understand this new threat and make useful projections. And since March 13, dozens of people have been meeting daily via Zoom to build models, to work together, to try to provide information that's useful as the world has navigated COVID. And so I'm sort of starting now with sort of my acknowledgements, but the work I'm going to talk about today was really done by a large number of people from many different institutions, many of whom are at UT, but also people from all over the world. And I also want to acknowledge the decision makers, mayors of cities, folks at the CDC that have really helped us to steer our work so that it could be as useful as possible. And let me also acknowledge the Texas Advanced Computing Center, which is listed there on the right, which is our supercomputer center, which has been a real partner in a lot of what we've done over the last few months. So what does this team, what does our consortium and what do other modelers like me do? Well, we really have 3 modeling goals. We model to help people understand the threat. How is it spreading? What can we expect? We model to forecast the threat. Where is it going to go in the coming weeks, months, years? And finally, we model to support decision-making so that we can do our very best with our limited resources to contain the threat. And throughout the COVID pandemic, we've been trying to address these goals for 3 different audiences. A lot of our work has been done directly to support policymaking, decision makers and public health agencies, elected officials. For example, this was an urgent modeling request, an excerpt from an email that came in from the White House Coronavirus Task Force very early in the pandemic when Ambassador Birx had just been appointed. Time-sensitive and urgent requests, they basically gave us a 24-hour turnaround if we wanted our models to inform policy. Doesn't actually seem like the models inform policy, but we provided the results anyway. We are modeling for the public. This is not something we usually do, but in the context of COVID, we have really seen kind of a use for helping the public understand what the data is saying, helping the public understand how this virus is spreading and how their behavior, their choices really make a difference. And finally, you know, arguably our most important audience is other scientists. So we have seen science progress at a pace, you know, never before, at least in the 21st century in my field, where scientists are doing studies almost overnight. They're disseminating them through preprint servers and through publications, and really standing on each other's shoulders and advancing the tools that we're using at lightning speed. So what I'm going to do in the rest of today's lecture is I'm going to go give you sort of a whirlwind tour of some of the work that the consortium has done since the beginning of the pandemic that really is spread across those three different goals of describing the threat, projecting the threat, and containing the threat. So let's start with understanding the threat. And a lot of our work in sort of just using models to get basic understanding to interpret the data was really done in the very first few weeks and months of this pandemic. So at the outset, really within days of hearing about this anomalous virus spreading through Wuhan, we realized that there were some key questions that we didn't yet understand. We didn't know, first, we didn't even know how the virus was spreading, whether it was even spreading from person to person. But then once we gained that understanding, we didn't know how many people were already infected in Wuhan, how fast the virus was spreading in Wuhan, where else it might already be emerging around the globe. And we didn't trust the data coming out of China, partly because China may not have been totally transparent, but partly because we were hardly testing for this virus. So even if we were willing to, they were willing to share all the data, they didn't actually know how much infection there was in Wuhan or elsewhere. So what data did we understand? What did we trust at the time? We trusted the reports of the first 19 cases outside of China, the first cases in Bangkok and Tokyo, Seattle, Chicago. We had access to exhaustive global air travel data. So on a daily basis, how many people were flying to and from Wuhan from all other cities around the globe. And we also, thanks to partnership with some Chinese researchers, we very rapidly got access to cell phone mobility data that told us on a daily basis how tens of millions of Chinese people were moving between about 370 different cities in China by air, by rail, by ground. So we used the data we could trust to sort of triangulate to figure out a couple things. How fast was the virus spreading in Wuhan? And how many other places around China likely already had outbreaks unseen but underfoot? And what we discovered from our fairly simple statistical analysis of the data was that the virus had spread far and was spreading quickly. By the time of that Wuhan lockdown on January 23rd, China had reported a total of 425 cases. Our modeling suggested that by that time, there were actually probably 12,000 cases or more. And subsequent modeling has confirmed that there probably were tens of thousands of people already infected by the time Wuhan locked down. Our modeling also projected that by the time of that lockdown, there were probably hundreds of cities all across China that were already brewing outbreaks. And certainly in the weeks following, they discovered that they indeed had outbreaks already underway. The second and most jaw-dropping of the studies that we did early in the pandemic, but actually the simplest sort of mathematically, was a study that we did in January and February, where we really realized how stealthy this virus is and how much more difficult it was going to be contained than the original SARS virus in 2003. In this study, we worked again with a group of Chinese students this time to collect data that was posted on websites of 18 different public health agencies in different provinces in China. And what the Chinese students looked for were case reports where there were sort of four pieces of information. There was a person who got the infection, the date they first had symptoms, the person who probably infected them, and the date that that person first had symptoms. And we needed those two dates of symptom onset to estimate that quantity I told you about earlier, that serial interval, how long between me feeling symptoms and you feeling symptoms. And we simply plotted the distribution of those serial intervals across the 450 case reports that we were able to find and translate into English. And as soon as we plotted this graph, we knew we were in trouble. There were three things that were really shocking. First, this virus was spreading quickly. This is what I told you earlier. It's spreading about twice as fast as SARS, with a serial interval of about average serial interval of about 4 or 5 days. The most shocking thing was that there was evidence of silent transmission. There were a handful of these case reports where it was clear that the person who was the infector actually didn't develop symptoms until after the person they infected. So this was the first evidence of this pre-symptomatic silent transmission. And then finally, we also saw that there were sometimes it took a long time for someone to spread the virus to another, meaning we'd have to isolate people for quite a while to prevent transmission. And when we shared this plot with our colleagues at the CDC long before we published it, their response was, "You must be mistaken. Go back and check your data, go back and check your math." And in fact, we weren't mistaken. And shortly thereafter, a number of other studies provide confirmatory evidence that this thing really was spreading as silently and as quickly as we learned from this data. The last example I'm going to give you of modeling just to characterize a threat is closer to home. This is work that we did for the city of Austin. So like many cities, the city of Austin went into a stay home, work safe order, or shelter in place order towards the end of March. Ours was enacted on March 24th. And our local work stay home order mandated that most construction work had to stop, except for really essential projects. And within a couple of days, the state of Texas overruled that. And they said, no, all construction work is allowed to proceed in the state of Texas, no matter what your local order says. And the city leaders were concerned about that. And so they asked us, when we were working very closely with them to model the situation in Austin, they asked us, what might happen? What were the risks going to be if we allowed construction work to proceed? Risks both to the construction workforce, but also the risk of spillover of virus into the community from construction work, to the rest of us. And so we made some simple projections. This is long before we really had the understanding we have today of the virus, but this is based on our first models. We made some simple projections like what you see in this graph. So the y-axis here is the hospitalization rate. And there's two different scenarios. Baseline risk on the right means that it's kind of what we estimated to be the expected risk of transmission if somebody arrives sick at a construction website, infected a construction, not website, work site. What's the chance that they would infect others at the work site that they work with? And the 50% risk is a scenario where their employers are taking measures to prevent transmission at work sites, reducing the risk by 50%. And then the two bars, the bars on the right where it says construction workers, that was our projection for the COVID hospitalization rate among the workforce. And then the ones on the left are the comparison to everyone else who's not being forced to go to these sort of low-paying, high-contact jobs, and that were mostly staying at home. And what we projected was that construction workers would probably have a 5 to 10, or actually 4 to 8-fold higher risk of ending up hospitalized for COVID compared to other people in the same age group with different jobs. And this was, an alarming projection, but there was nothing we could do except advise construction employers to take precautions to protect the safety and health of their workers. And then the city of Austin, because they were concerned, they started tracking and they started asking hospitalized patients what their occupation was. And we were tracking it. And what we found was that unfortunately our projections were borne out. And so what you're seeing here is these are the actual number of COVID hospitalizations in Austin, Texas through, I guess, early May. The total heights of the bars are total numbers of people hospitalized. The dark line is the projection of our model, and the different colors show you who was in the hospitals. The darkest line is construction workers. The medium color are people who reported their occupation and they weren't construction workers, and the others are either people in different age groups or who didn't report the occupation. And when we calculate the relative risk of COVID hospitalization in construction workers versus other 18 to 49-year-olds, we found that actually through the end of August, construction workers had a 5-fold higher risk of ending up hospitalized with COVID. So this is really, just now one of many examples of how our most vulnerable populations have been at really high risk of not only being infected, but ending up with severe outcomes. And in Austin, 66% of our construction workforce is Latinx across the United States. 30% of the workforce is Latinx. Among Latinx construction workers, 48% lack health insurance, which means that they've had a chronic lack of access to preventative care, resulting in higher rates of comorbidities of underlying conditions that put them at higher risk for severe outcomes, and also more likely to delay or not at all seek treatment for COVID, which can lead to much worse outcomes from the infection. Construction workers are also more likely to smoke than other occupational categories and more likely to be exposed to hazardous materials. They are more likely to go to work out of economic desperation, meaning that if they have symptoms, they may feel like they still have to go to work to put food on the table. thereby making themselves more prone to severe outcomes, but also more likely to expose their other people who they work with. And they're also more likely to live in large households, leading to higher likelihood of spillover into their homes and into the communities. So this is a really stark example of what we call overlapping vulnerabilities or overlapping exposures in a population that has to work, that isn't being protected by our stay-home orders and other orders, and that has a lot of other reasons why they may be at higher risk for both infection and severe outcomes. And I think it's really tragic how we sort of keep throwing our essential workforces basically under the bus, and it really is it's up to us, it's up to our communities to continue to try to do things to protect these communities, including incentivizing workers to stay home if they or any member of their household has even the slightest symptom of COVID, and including providing alternative work accommodations for people with known high-risk conditions that are likely to end up in the hospital or worse if they get infected. So with that, I'm going to turn to the second modeling goal, and that is forecasting the threat. And the very first request that we got to forecast the threat of COVID came from the White House Coronavirus Task Force very early on, I believe in March. And the question was, how many people are going to die by the end of 2020 from COVID? And our answer was, there is no way to project that without knowing what policies you and local officials are going to put in place, and how people are actually going to behave under those policies. But we'll give you some sort of if-then, we'll give you some conditional projections. And the projections were that if we don't do anything and we just let this virus spread completely unmitigated based on what we knew in March, that we could easily see over 1 million deaths in the United States by the end of 2020. That if we went into shelter-in-place orders and we maintain them indefinitely through the end of the year, we could limit deaths under 50,000 due to COVID. And that if we do something in between, which is basically the roller coaster that we've all been riding, the deaths will probably total somewhere between 200,000 and 400,000 by the year end. And unfortunately, we're on track towards that sort of grim goal right now. But that was sort of a very simple early projection. Since then, we have been working to try to build more sophisticated forecasting models, but it is extremely difficult for the reason I just mentioned. Unlike forecasting the weather, where no matter what we do as people, the weather's going to do what the weather's going to do. When you forecast a pandemic, that might actually change behavior, change policies that change the fate of the pandemic, and then render your forecast wrong. So, without a crystal ball about human behavior and policymaking, it's very challenging to forecast what this pandemic is going to do out more than 3, 4, 5 weeks. But nonetheless, we and others around the globe have been working hard. We are one of now, I think, over 30 groups that submit on a weekly basis to the CDC's COVID-19 mortality forecasting ensemble. So you can find UT in this list of many projections that are up there on updated regularly by the CDC. Our first foray into forecasting was inspired by a different forecasting model that got a lot of attention early in the pandemic. It was out of a group in Washington called IHME. And they have a really nice interactive website that has been, I think, widely used by the public and widely cited by the White House and other decision makers at different scales, providing projections for deaths, hospitalizations, cases. When this model was first launched and came to the sort of national attention, it also got a lot of flack from the scientists in my field. And that's what you see there on the right. It's an article in a magazine called Stat. Influential COVID-19 model uses flawed methods and shouldn't guide US policies. And there were some pluses with this approach, and there were some minuses. One of the key challenges with the way they approach this modeling is that they assumed that the deaths would start slowing as soon as governors enacted stay-home orders, statewide stay-home orders. So they assumed everyone was like living life as normal up till that point, and as soon as governor enacted orders, the virus would stop spreading. And we know that the behavior and the transmission was much more nuanced and varied both in time and space. This is an example of a backcast where we asked how well did their model forecast when we can go back and compare it to actual data. And what you see in that shaded region is their forecast for a period of time in April in Spain. And the dots show that what actually transpired is different than their forecasts. Well, our modeling group, although we weren't really planning to go into forecasting, we decided not to throw the baby out with the bathwater. There were certainly some redeeming features of this and really innovative aspects of their model. So we decided to try to correct and improve their model. So we used their basic approach, and instead of making these sort of unrealistic assumptions about that transmission would dramatically stop when governors enacted their orders, we decided to look for data that would tell us on a daily basis how people were behaving and how fast the virus might be spreading. So we built a model that looked a lot like theirs, but instead of making those assumptions, we used cell phone mobility data from all around the country to sort of estimate how much people were out and about in ways that could lead to the transmission of the virus. This data is provided by a company called SafeGraph that makes a really rich data source about human mobility available to all researchers for free. This is an example on the right of what the data look like. These are time series graphs showing people's behavior in Austin, Texas. That top line is how many hours a day people are staying at home throughout from, I think, sort of early March. I think this went through maybe September. And the other lines are showing you how many visits per day to places like restaurants, bars, grocery stores, parks, et cetera. And so that early uptick in time at home and downtick in all these visits, those show what happened when in Austin, we closed our schools and then went into a local order. So we integrate this kind of data into our projections as sort of a real-time indicator of how people are moving about and potentially spreading disease. We now have and we've actually changed the model, the structure of the model as we've learned more about the virus, over the course of the pandemic. We maintain projections in addition to feeding them to the CDC. We maintain our own dashboard that you can go to. We provide projections at the level of the entire United States, but also all 50 states and 100 or so of the largest cities, including the Milwaukee area. And you can see our 3-4 week out projections for deaths due to COVID. We also have built models to look in more detail at what's going to happen with hospitalizations and particularly focus those efforts on Austin and in Texas. We have a dashboard for Austin. We have a dashboard for the rest of Texas. This is sort of a snapshot. What you would see at the top of our dashboard, we're providing key indicators. We're estimating something known as the reproduction number of the virus. So the reproduction number of the virus it tells us something about how fast the virus is spreading in our community. One way to think about it is it's the expected number of people that you will infect if you get sick. So if the reproduction number is 2, that means on average, every infected person spreads disease to 2 others. And a value of 1 is a really important threshold. If the reproduction number in a community is above 1, that means we expect the pandemic to continue spreading exponentially. And if the reproduction number is below 1, that means we actually expect the pandemic to fizzle out sort of on its own. And so we keep a close eye on that as an indicator as to whether the pandemic is growing or decreasing in our community. So on the day that I took the screenshot from, our reproduction number was estimated to be a little bit above 1. We estimated an 88% chance the pandemic was growing in the community at the time. And that compared to 2 weeks before, we had approximately 44% more infections. We make these estimates using a model that takes 3 pieces of information: the daily number of new admissions into area hospitals for COVID, the daily number of COVID discharges from our hospitals, and then that SafeGraph mobility data for the region. We also on our dashboard, and the main purpose of this dashboard is to make short-term projections, is to tell city leaders and people who live in Austin how quickly our hospitals and our ICUs are filling up. And this is particularly important right now as we are sort of on the brink of overwhelming rushes on our hospitals all across Texas. And it really helps policymakers understand, do we have 2 weeks? Do we have a month? Do we have a matter of days? And helps them to make decisions. We also on our dashboard allow people to look back. So this is a time series showing that reproduction number since the beginning of March. So again, that's telling us how fast it's spreading. And as we look back in Austin, and if we look back in Milwaukee and any other city, you can usually tell a pretty sensible story. So prior to closing schools and enacting our stay home, work safe orders in Austin, when we were living life in sort of ignorant bliss, not realizing this virus was spreading, the virus was spreading very fast with a reproduction number probably somewhere between 2 and 4. And then our early measures had the desired effect of bringing our reproduction number down close to 1 or below 1. Then with the reopening or the opening up of America again, that started in May 1 with vigor in Texas. And then, phase 2 in mid-May, we saw the consequences of that. We had a really alarming surge of hospitalizations in Austin and Texas and many other Sunbelt states that led us to enact local orders to slow things down in mid-March, and then state level closing of bars, closing of state mandating of masks. And then we sort of had we were able to kind of keep things under control for a while. UT opened, we had about 30,000 students come back to Austin towards the end of August, and things have sort of been ratcheting up ever since then. And we're at a really sort of alarming moment right now. Like I said, we're doing this for all of Texas. Texas is absolutely on or over the brink, depending on what city you're looking at. These are ICU projections for the 22 different regions of Texas. And you can see in the horizontal lines are our estimates for their ICU capacity. And you can see, and as you've heard in the news, a lot of our communities are really inundated right now. So finally, I'm going to shift gears and talk about containing the threat. And this is actually where most of our effort has been over the sort of 9+ months of the pandemic, is working very closely with decision makers, local policymakers, CDC, schools, other people just trying to make decisions in a really sort of uncertain and precarious moment. And I'm going to give you really just one example of how we've been doing this with the city of Austin. Austin, like many cities and states and countries, has established a very clear alert system that is depicted here. This is a screenshot from the city of Austin's key indicators for staging dashboard. It's following one particular piece of data, and based on whether that data is in red, orange, yellow, or blue, it tells us what kind of restrictions are going to be in order. So red means basically we're in a stay-home order, orange is we're pretty restricted, yellow is less so, et cetera. And the particular data that we are following in Austin is the rolling 7-day average of COVID-19 hospital admissions. And we worked very closely with the city of Austin. That includes our mayor, our judge, the CEO of all area hospitals, the dean of our medical school, and other experts in the city. We've been working with them since April to develop this policy and to make sure it's still on track and to kind of just navigate the changing landscape of COVID. So how did we, and so what did we actually do as modelers? Well, we helped to sort of articulate what this policy should look like, but the sort of the heavy lifting of the math and the computing was actually figuring out where to draw the lines between red, orange, yellow, and blue. And I'm not going to go into the detail, but I'm going to give you sort of a sense of what we did. So the first thing we asked, and this was as we were looming towards May 1st, and we were worried about what the reopening would do, we asked, what if we did nothing? What if on May 1st, Texas and Austin opened up and we didn't enact any other measures? We gave people the benefit of the doubt that they wouldn't go back to life as normal. They would still take some precautions, but they wouldn't take a lot of precautions. And our prediction was that if people went back to life sort of at reducing transmission by 50% relative to what it was like before we enacted any measures, then this is what we projected for Austin, that we would see an enormous surge with lots of deaths, and we would quickly exceed, or by the end of the summer, probably exceed our hospital capacity. And nobody wanted that. But the reopening of Texas and state laws were prohibited Austin from really enacting very strict measures. So we had to come up with a policy that would be acceptable from sort of a state perspective, a legal perspective, but also achieve our goals. And so the question was, what should we do? And the most important step I think we took as a group was to figure out what our goals were of whatever policy that we were going to put in place. And thinking about those constraints from the state and thinking about what we really wanted, which was to protect lives and protect livelihoods, we came up with two goals. Our goals were to ensure that we keep our hospitalizations under capacity. We never ended up in a situation like we were seeing in New York at the time. And we, at all costs, or as much as possible, avoid restrictive measures. We want to not end up in red. We want to not end up in orange. We want to stay in yellow and green and blue as much as possible. The policy options were sort of that portfolio of different kinds, combinations of how big can your gatherings be? How are you going to open your schools? Are you going to open hospitals? Restaurants and bars, et cetera. So the options were a wide variety of different face masks and social distancing gathering restrictions. And so after working together really for months and building some models and using some optimization methods to search through very large policy spaces to figure out exactly what our thresholds should be, we came up with a couple solutions. The first was that the best data to track to get a good real-time sense of how fast the virus is spreading in the community is not cases, is not test positivity, is not deaths, is not total number of hospitalizations, but is the number of new hospital admissions and discharges into area hospitals. It has the least bias and it's the most real time. And that's sort of a whole story unto itself. But unfortunately, it's not data that's easy to come by, but it's much more useful than a lot of the other data that are on dashboards around the country. And then the other solution was to tap on the brakes at those key thresholds between those numbers that we derive for red to orange, yellow, et cetera. So how will this policy that has now been in place since the beginning of May, how will this play out in the months to come? We don't really know. It depends on whether Austin follows it. It depends on whether, and the state allows it. It depends on whether the public complies with it. And it also depends on when we get vaccines, how we use testing, et cetera. But this is one possible, I wouldn't call this a forecast, but this is one possible, what I'm going to show you is a scenario where we sort of assume that we're going to play by the playbook. What you see on the top is that 7-day admission thing, that hospital admissions that we're tracking. You see the actual data as red dots. And what you see are model projections. Each one of those turquoise lines is an equally plausible future projection of our model. The darker line is one of the sort of middle projections. It's sort of a typical projection. And you can see with these horizontal bands, how much of our time we expect to be in orange versus yellow versus red. And what you see is that there's a decent chance a lot of these trajectories do land us in red for at least a little bit of time. There's a decent chance we're going to need to lock down at least temporarily in the next few months. But we're going to have to spend a lot of our time until we get vaccines really rolled out. We're going to spend a lot of our time kind of in this semi-restrictive mode. And what you see on the bottom is the prediction for the thing we're trying to prevent, which is, are we going to see overwhelming numbers of ICU patients? That horizontal line is our capacity for Austin. And what we see here is that if all goes as planned, there is a small chance. There's actually, we solved for solutions that keep the chance under 5%. There's a 5% chance that we will exceed our ICU capacity by a little bit, but 95% of these projections project that we will have a lot of people in our ICUs, but we should preserve our capacity. And that sort of I guess, what is that sort of Miro looking color scheme in the background? If you look at a single day, the amount of like that column that's red versus orange versus yellow versus blue tells you what percent of our projections are in red on that day, are in orange. So in other words, what's the probability that on that day we'll end up in a stay home order? And so that's what it projects. And so far it has served us well. Actually, just this morning, based on analyses we did in the last 24 hours, we actually just pulled the trigger on going to orange, and our public health authority and our mayor had a press conference this morning. We actually pulled the trigger a little bit earlier than our dashboard tells us to, and that is because we no longer have as much capacity in our ICUs, because we have patients from El Paso in our ICUs, and we have some of our healthcare personnel working in other cities to relieve more strained communities. So how does this compare to other alert schemes, right? As you look around the globe or you listen to the news, you hear, France just went into its highest state because its ICUs are 30% filled with COVID-19 patients. Or you hear that Seoul, Korea just went into level 1.5 for some reason. And so there's these dashboards, there's these triggers all around the world. And when you look close and you go to the public health websites, they typically don't tell you how they decided to track the data they're tracking. Sometimes they don't even tell you what data they're tracking. And they don't tell you really how they came up with the thresholds they came up with. And they may be based on really good, science and analysis, but we don't know. And so we've started to try to sort of look at, take these things and say, what if we implemented these kinds of strategies in our model, and compare how these policies will do. And we're comparing them the same two dimensions that I talked about earlier. How long do we end up in a stay-home order, which is something we want to avoid? And what's the chance we're going to end up exceeding our ICU capacity, which is the other thing we want to avoid? So what you see here in this graph are the results of our model simulations. Each dot is a result of a single simulation, and the different colors represent models of different alert systems. So I'm just going to talk about 3 of them. The black dots that are there across the bottom is this Austin system that we developed. And it does in our model what it was designed to do. You can see that it's towards the bottom, which means not too many days in lockdown, not too many days in red. And it mostly stays to the left of that ICU capacity thing, meaning that most of our projections say that we will stay under ICU capacity. So we've run like 300 simulations, and usually it does what it's supposed to do. The next one I'm going to mention is the France one. So this is, and I mentioned this a minute ago, France has a thresholding where they are monitoring their ICU capacity. And when they get to 30% full, they go into basically orange. And when they get to 60% full, they lock down. And under that, and under their stage strategy, we actually project that they kind of err in both directions. They probably spend more time in lockdown than needed. Well, actually, I wouldn't say it that way. They don't protect enough against overwhelming ICUs. And so under that strategy, we are more likely to end up having overwhelming surges in our ICUs. And because of that, because we wait too long to lock down, we end up having to lock down for longer while we wait for the peak to really dissipate. And then the other one I want to mention is a really widely cited, widely used set of guidelines from Harvard Global Health Institute. It is this guideline that you may have read of, or you may even be using for reopening, and it's based on cases. And it's roughly when you get to 10 per 100,000 new cases per week, you should start to shut down. If you get to 100, you really need to shut down. And under their policy, that policy really errs on the side of caution. It does a really good job of ensuring that our the healthcare demand never gets close to capacity, which is a good thing. But it results in, as opposed to an expected sort of about 2 weeks of lockdown, under the Harvard thing, we project that it's probably a community will be in closer to 9 weeks of lockdown. So that's really what I wanted to share with you today. I'll tell you what we're working on sort of on a daily basis, what the team is working on right now as we speak are kind of a few different key things in navigating the months ahead. We've been thinking a lot about, and we have been since really the middle of the summer, about how we can safely open and manage schools and colleges. We're turning our attention now to how do we manage the return from Thanksgiving and winter break. This is a screenshot of a model of ours that appeared on the front page of the New York Times that was meant just to give very basic county level guidance estimates of what is the chance that someone will show up infected if you open schools today as a function of how big your school is and what county you live in. This was published in the summer in late July and was never updated by the New York Times. And so we just recently released our own version of it that's updated on a daily basis that allows you to say, depending on where you live and how big your school is, how many people would we expect to show up next week infected? So for example, I don't know if you can see this, squint your eyes. What you should be seeing on your screen is I've zoomed into Wisconsin and I've put my mouse on Milwaukee County, and based on today's numbers, so this week's numbers in Milwaukee, if you have a school of 100 kids and they all show up, you would expect 3 of those kids to show up infected, just based on the numbers in your community. So you can go to our website and play around with this and see this updated along with our mortality projections for Wisconsin if you're interested. We are also working quite a bit on thinking about how we can really leverage surveillance testing to help reopen our economy, reopen schools as safely as possible. As cheap and accurate tests become more widely available, it can really be a way we can bring people together, do more of what we want to do while mitigating the risk that someone will show up infected or spread the virus to other people. And then we are also starting to work with local and state authorities and the CDC and thinking about how to optimally roll out vaccines in order to most quickly mitigate the spread of the virus. Let us get back to our lives and save the most lives. So lessons learned. I think, a lesson that we have all felt is just sort of really a failure of preparation. And the reason I bring up these 2 slides that I was sort of bragging about earlier is that these 2 pictures was that we developed what were some, really some pioneering tools in a very unique collaboration with the state of Texas in the aftermath of the 2009 pandemic. And the state and we were very motivated to build tools so that we would be prepared for the next one. The state spent a lot of money on these tools. And then I would say by 2015, they were shelved and completely forgotten about because we lost track of the fact that pandemics are something that we need to worry about and plan for. And so we really, I think we have a somewhat impoverished public health system. We have a lack of bridges between the public health system and scientists and policymakers. And so, and we lost track of pandemics being the important thing. We shifted our 2009 H1N1 resources to Ebola and then to Zika and now to COVID. And we really need to be preparing for all possible threats on a continual basis. And we need to be resourcing our public health agencies to do that. Also, there's been sort of an utter failure of imagination. So I have been working in the field of modeling pandemics for, my whole career, almost 20 years. And, most recently, I mentioned earlier, the projects we were doing for the CDC to build pandemic models. And I would say 95% of those exercises and those efforts, we have been assuming that the next pandemic was going to be an influenza pandemic, that we would have a 6-month time horizon to having vaccines. We never really considered the chance that we would need something like shelter-in-place orders to mitigate. Really didn't think about surveillance testing, all the things that we are scrambling to sort of figure out on the fly. We really just didn't imagine pandemics that were very different from threats we've seen in the past. And we really need to sort of expand our imagination, really think about the vast universe of possible threats that we might see in the future, not just what kind of virus, what it might do, but really how a pandemic can cascade and impact all of our social and economic and global systems, and really understand those interdependencies. Other lessons that we have learned in our work is that this unfortunately very short forecasting horizon, we really can't predict what this pandemic is going to do because we can't predict. We know a lot about the virus, but we don't have a crystal ball for behavior, for politics and policymaking. We don't have a crystal ball for innovations, right? We didn't really know when the vaccines were going to become available. We still don't, how effective they're going to be and how many people we're going to be able to vaccinate on a weekly basis. And we also didn't anticipate, we don't have a crystal ball for those exogenous events. That hurricane that, caused 15,000 people to come for, 5 days from Galveston to Austin, right? That can really change the dynamics of transmission. So in the future, we really need to think about, can we forecast things further out and how do we incorporate these kinds of less predictable factors into our models, collect data on these things. Kind of more in the weeds, from that last study I showed you, some policies, some of these alert systems are better than others, and probably very few are validated in a really data-driven way in the way that we are doing it. Timing is absolutely critical. Waiting until your ICUs are full to slam on the brakes is waiting too long. We need to be slowing things down in our communities at the first hint of an uptick. And I know you're feeling that in Wisconsin, and we're feeling that in Texas. Tracking hospital admissions is a key indicator of how fast the virus is spreading could be really useful. It's a data source we should all be collecting. In fact, I noticed it tucked in one of the line items in Biden's plan, and I really hope that comes to fruition for future threats. And one thing we've learned in Austin, in Texas, probably you're learning this in Wisconsin as well, and we didn't learn this really until the summer, is that really the limiting healthcare resource is not hospital beds, it's not even ICU beds, but it's trained ICU personnel that can actually care for our most critical patients. That is our real shortfall at this point. And so with that, I want to thank you again for this invitation. Really nice to know friends and family are in the audience. Be back in Milwaukee virtually, and once again, acknowledge the amazing team that did the work that I shared with you today.